in here. Okay, I guess that means we're ready to start. All right, well, I'm going to call to order our Board of Health meeting for today, September 25th, 2025. And first item of business is roll call. I do believe we have one of our board members online. Liz, are you with us online, Liz Henry? Just want to make sure she hears me.
Yes, I'm here.
Okay, wonderful. Thank you. Can we start with Ray and go around the table? Introductions?
Ray Byrne, Environmental Public Health Division Director and Interim Administrative Officer.
Dr. Velasquez, Health Officer for Spokane County.
Mary Kinney, Spokane County Commissioner.
Josh Kern, Spokane County Commissioner.
Patricia Keenholz, Public Health Consumers.
Charlie Duranona, representing community stakeholders.
Ann Pittsnoggle, Recording Secretary.
Michelle Fossum, Legal Counsel.
Monica Blankowski-May, representing providers.
Michael Cathcart, City Council Member and Vice Chair of the Health Board.
And I'm your County Commissioner, Amber Waldruff, and Chair of the board this year. So welcome, everyone. We first always start with citizen input. Do we have anyone signed up, Anne? We have a couple folks that have signed up, and first is Chris Curry, who wanted to provide some input to the board. Welcome. And we have, I'm looking here, is it, what's our time frame that we usually give?
3 minutes.
3 minutes. Oh, and there's the little timer. So thanks for coming down. Go ahead.
Good afternoon. I guess this is on. I think so. Yeah. Hello. Okay. My name is Chris Curry. I'm a retired home health RN from Spokane and a volunteer with Healthcare for All Washington. I'm here this afternoon to urge the Health District to continue its steady progress on implementing its very commendable health equity response resolution and its evidence-based guidance with regard to vaccines, regardless of the disarray, false information, and threats of funding cuts now being promulgated by the CDC and the Trump administration. While I can support the clarified policy definition of equity in the amendment, since it conforms to the Washington Department of Health and the Healthcare Authority's equity definitions, I fail to understand why staff training in its implementation would not be mandatory. I would hope that the training would at least be strongly encouraged, since the Health District has taken such a firm stance on promoting equity. I would also hope that hiring, in compliance with Washington's broadly based law against discrimination, means that you will be continuing to include demographic, cultural, and linguistic diversity as one important qualification for employment in order to best serve the Spokane area's disparate populations. I further hope that the Health District will fully support recommendations by the newly formed West Coast Health Alliance in countering RFK Jr.'s efforts to make America diseased again. In the long-term interest of the common good, mass non-cooperation is therefore the difficult but necessary response to Trump's nonsense and bullying, not subservience. Thank you.
Thank you. I have John Sherrick on my list as well.
Thank you. My name's John Sherrick. I'm a family practice physician. I practiced in Spokane for 27 years. And following that, I was on the faculty at University of Washington School of Medicine for several years. The scientific method was developed during the Age of Enlightenment in the 17th century. And it's what we in the medical fields rely upon to provide best practices for our patients. But it is being ignored and undermined by the current administration. Instead, leaders like President Trump and RFK Jr. Advocate policy changes by making claims that are not supported by any credible body of evidence. As you're aware, they're advancing their bogus agenda through funding cuts, firings of staff, threats, bullying, and intentional spread of misinformation. Now, I understand how difficult your personal and professional challenges are as you try to negotiate how to respond to this crisis. But I just want to urge you all, on behalf of many, many colleagues of mine, to stand up to those administration officials who act in ways that compromise the integrity of our nation's healthcare. So please do everything you can to prevent this desecration of evidence-based medicine and the dismantling of our public healthcare system. Thank you.
Thank you. Is there anyone else that would like to give comment? Hi, Joe. Can you introduce? Can you give your name for the record?
Alexander Joe Shogan, Shogan Jr. I'm a lifelong Spokane resident except for 4 years in the Army, a year in the seminary, combat veteran. I was president of City Council. I'm aware of the responsibilities of this board. And to me, the responsibilities of this board are the health and welfare of this region. And despite what comes out of Washington, D.C. and worm-brain Kennedy and Tylenol Trump, with all due respect, your job is to protect us, our region, despite threats of funding cuts or anything else. The reality is, and I'm speaking on behalf of Dr. Steve Laney, who couldn't be here, whether you do your job and it results in funding cuts is still your job. So I encourage you, and I echo, we're looking at undoing years of scientific research for a man that's a drug addict, claims he has a worm in his brain, is not a doctor, and has really gutted the vaccine research in this country because he doesn't believe in vaccine. Well, RFK Jr. shouldn't be dictating my health care. My wife's a neonatal nurse. This man's going to do so much damage if we don't continue with vaccinations for newborn, especially hepatitis B and MMP, or measles, mumps, and MMR. So I encourage you to stand up. If you took an oath, stand up to your oath. If not, your responsibility is to the people of this region. And that means the health of this region, despite opinions that are coming from out of this region, out of this state. So if your personal beliefs are you agree with RFK, I suggest you resign and get another job. Thank you.
Thank you. Anyone else wanting to provide input to the board? Going once? Going twice? Okay. Thank you. We'll start with our board reports here on our agenda. So, chair report. I don't think I have too much to report today. We had our last full board meeting. We had a special meeting at the end of August. And since then, we had one executive committee meeting where we planned the agenda for today's meeting. And I think most of the focus has been on the budget. And so I think I'll ask Commissioner Cuny to give an update, because I know today we're going to hear some budget proposals, and the budget committee's been working really hard to bring those forward with the help of Kim. So Commissioner Cuny.
Thank you, Chair. So we had our Budget and Finance Committee meeting on the 18th at 8 a.m. We are proposing, I think today we're going to be talking about the fee schedules. Yes, that we do recommend. So the fee schedules proposed 2026 proposed fee schedule and then proposed budget that we're looking at. Kim, after our meeting, did come and present to the county commissioners. So we understand where their budget is from the commissioner side on the extra funding that we provide. We looked at the resolution that's coming forward today and recommend all those things to move forward to the board. And then I did have to leave a little early, so I think you guys reviewed the vouchers and the financial report at that point, but I know Kim will be giving us an update on that as well. So, so the proposed fee schedule and the resolution was recommended by the Finance Committee.
Thank you. So you'll see later on our agenda today the financials. So we're going to get a presentation on the proposed fee schedule. So that's any fees that the health district charges for different services, and most of those come out of Mr. Burns' department. So he'll be leading that discussion with Kim, and we'll be looking at the SRHD budget for 2026. So thanks for all your work, the two of you, to look in every little budget area to see where we can be as effective as possible. So we'll look forward to that. So we're going to move into executive session. So I'm going to hand that over to Michelle just to state the purpose of the executive session.
Thank you. So the board will be in executive session for two separate reasons. One, potential litigation pursuant to RCW 4230-110-1I, and then also review performance of a public employee under RCW 4230-110-1G. It's anticipated that we'll be in executive session for 30 minutes, and at least to start with, it'll be just the board members and myself, although we may ask Mr. Byrne to step in midway. So that's everything.
Okay, so we're going to let folks leave the room so we can do our exec session, and if you want to remain, we'll be back in 30 minutes, hopefully. And if we have to extend, we'll make an announcement. Thank you. We are back on air. Welcome back, everyone. We're back from executive session. The next item on our agenda is our consent agenda, number 6. And it includes A, B, and C on our agendas, our agenda here. Looking for a motion to approve our consent agenda.
I will so move the consent agenda.
Okay.
I'll second.
Okay, motion and second. Any discussion on any of the items on the consent agenda? Okay, hearing none. All those in favor say aye.
Aye.
Aye. Any opposed?
Aye.
Okay, and Ms. Henry, that was an aye?
That was an aye.
Okay, thank you. So we've unanimously approved the consent agenda. So we'll move on to item number 7, an action item. And this is a resolution appointing 2 interim administrative officers in the absence of the administrative officer. Michelle, did you want to walk through this for us?
Sure. So it is important and necessary for the board to officially appoint folks to be at the helm during the absence of the administrative officer. And so this resolution would formally appoint Ray Byrne to handle issues of operations and Kim Kramer as controller to handle issues of budget. And then it also has a provision to potentially increase the pay from today going forward for those 2 individuals and because of the extra responsibility that they will be taking on. So that I think is the outline.
Any questions on the resolution or comments?
No, I'll just say again, the Finance Committee reviewed this and approved it. So I would like to make a motion to approve this, and I'll also be adding an amendment after we make the motion to approve this resolution as presented.
Okay, if there's no other.
Second.
Do we want to amend it first? Okay.
Yeah, amend it first.
Sorry.
Okay, go ahead, you have the floor.
Okay, so I would like to amend the motion that on resolution 25-03, section 4, that we change the compensation increase to 15%, from 10% to 15%.
I'll second that motion.
Okay, any discussion on the motion? So this would be 15% to the current salary of each of the individuals that you outlined. Okay, in their role as interim administrative officers and the additional work for Ms. Pittsnoggle. Okay, if there's no comments or questions, I'll take a vote on the motion on the floor, which is to, again, to have a 15% bump for each of those individuals in this capacity. Looking for a vote. All those in favor say aye. Aye. Any opposed? Okay, thank you, Ms. Henry. So I think we have unanimous approval of item 7A, or the amendment to 7A. So now we need to take action on the amended resolution. So looking for a motion.
So I make a motion to approve item 23 or 25-03 as amended.
I'll second.
Okay, motion and second on the amended resolution. Any discussion? All those in favor say aye. Aye. Any opposed? Abstentions? Okay, I think that was unanimous then. Approval of 7A as amended. All right, we're on to reports. And Mr. Byrne, as our interim administrative officer, I know you have maybe a few updates, and we're going to get a treatment services report.
Yes. And do you control the PowerPoint? Okay. So just three little things here. So we just want to do a quick report out on the annual barbecue, have a couple of staff kudos to announce, and then we'll turn it over to Misty and Adam to do an update for treatment services. So here's some photos. So we had our annual barbecue here at the agency. This year, we combined it with our awards and recognition. Previously, that was held separately. We gave approximately I think there was 5 individuals that we awarded for years of service for 5 or greater years. And just wanted to give a big thank you to board members. We had multiple board members attend this year, and we had a lot of comments back from staff in recognition of that. They really appreciated that, and that was highly recognized. So, so big thank you for everybody that was able to attend that. This year was really well attended. We made more effort to expand it a little bit so that we could incorporate not only those working out of this agency, but also the WIC offices and treatment services. And so it was much more attended this year. Weather was beautiful. And again, just had the presence of the board members. So thank you for that. Here's some more photos. All right. Once a quarter, we do staff kudos. So kudos that come into staff for staff are accumulated, sent out to SRHD staff to vote on. And then from that, we choose the top 3 that will be brought forth to the board here. And I believe do we forward all of the kudos to the board or just these 3?
Just those 3.
Okay. So there was a number of kudos beyond these that were also brought forth. So I'll just read through these real quick for you, and then we'll turn it over to Treatment Services. So Irina Semko, who is a member of our health equity team currently. Irina Semko began at SRHD nearly 3 years ago as a community worker in immunization assessment and promotion. Early on, she built strong relationships with the Slavic-led organizations, becoming a trusted voice in a vaccine-hesitant community. She has helped create culturally appropriate vaccine resources, hosted health fairs, and supported newcomers from Ukraine by connecting them with local services. She has also helped with reviewing translations for immunization records for countless new families so that they can more easily enroll their children in school. This has also supported school nurses by ensuring vaccines are medically verified and improves the data completeness and quality within the statewide vaccine registry. Now in the health equity team, her commitment to education and trust building continues to benefit the community. We are thankful for Irina and the relationship she has built in our community. So thank you, Irina. The second one is for Lacola Champlin, and she is a member of our immunization assessment and promotion program. Lacola, administrative assistant for immunization assessment and promotion program, has turned Vax Central, which is our immunization and supply area. Thank you, Dr. B. This was noticed by the syringe services staff so that they reached out to her manager to see if she could apply these skills to the massive number of supplies in our program area. In no time at all, Lacola arranged, labeled, inventoried all the supplies, plus developed a coding system to allow staff to work more efficiently within the space. She brought order from chaos. The syringe services staff are extremely grateful for Lacola for sharing her creativity with them. So thank you, Lacola. And next, we have Robin Parks, who is a member of our payroll. On behalf of the procurement and contract team, we want to sincerely thank Robin Parks for her support during a very difficult time. Her professionalism, patience, and compassion made the meaningful difference, and your willingness to step in and help did not go unnoticed. It's during these times like these that employees like you really make a difference, and we are very grateful for your support. So congratulations to all 3 of those. And again, we had numerous others throughout the agency that come forth, but the process is just to bring 3 of those to you. So any questions from me? Okay, we'll turn it over to Adam and Misty with Treatment Services.
Thank you.
Good afternoon. Okay, so for today's update, to give you an idea, so August in your report, it'll show that we had a deficit for the month of August. And just as a piece of information, that actually was due to a claims issue, which has since been rectified and will actually be showing differently, and we'll see that number change significantly in October's numbers. So in October, you'll see that the August and September numbers reflect the more accurate claims. So that will be an adjustment there. However, even with that deficit, year to date, we have a $452,599 surplus in our budget, and the full numbers I believe, are in your packet. Questions? Okay. And our monthly numbers, again, these are the same that we've gone over each month, and this is updated for the month of August, and we have the intakes and dispensing numbers that are updated. And I'll give you all a moment to review those. We have the intakes, the days from referral to admit, intakes that have been turned away, intakes that returned after and were admitted, as well as our transfers and discharges. And then our dispensing is our unique OTP patients that have been served year to date, as well as the month of August, unique courtesy dosing patients, methadone doses, and our buprenorphine naloxone doses dispensed. Yes.
What are the blank spots on the far right under the yearly total? Why is that number so low, and what are those two empty boxes?
Are you under the 2024?
Yeah, so on the intakes,
So
where it has the yearly total, why is that so different than the 2025 one?
The two empty boxes where it
Yeah.
says 94 and 51?
Yeah, the ones next to that, or just where it says 0.43. Why is there such a difference in the numbers?
So we
those
weren't
2
asked
years?
to collect the specific data in 24. So we had it, I believe we began gathering it in December. So we didn't start collecting the specific data points until that time.
Thanks.
Yeah, if I remember, I think the board asked that you collect the data so we know how many people are being turned away just because of lack of capacity.
Yep.
So, okay.
Correct. Did that help?
Yeah, thanks.
Anything else? So again, our counseling for individual and telehealth counseling sessions, group counseling, and counselor assessments. And then our jail numbers for our jail doses and unique patients served, as well as jail assessments. Yes.
I was wondering with the jail services that you provide, is it, do you assess everyone, or is that based on when the intake process happens at the jail, are certain inmates flagged that may need some substance assessment, and then that's when they ask you to come and do that?
No. So what happens is an individual that may be incarcerated submits essentially a kite, and those come to us. And we actually have staff that go there. They receive those messages from inmates, and our staff go in there and essentially do triaging with those individuals to find out if they're appropriate for services, and then two, they then follow up to see what the charges are. Are they appropriate to engage in our program, or does it make sense to work with the jail to help them engage in services that wherever they may be going, if they're going to be going somewhere long term? So we do a triaging process with the jail staff as well.
That's all driven by the inmate themselves?
Correct.
Okay. And then, I mean, how often do you start providing a service and then they're released? And so then are you guys involved in connecting them to when they're released back to be able to access your services?
Absolutely. So once an individual is assessed and admitted into our program, and once they're in jail, they are then enrolled in services with us. And we have our community counselor position that provides counseling and goes up and sees the individual. They will help them collaborate with, if they've got a probation or parole officer, they'll help facilitate that in any way that they can. And ensuring that that individual has the information of what our location is, hours, what their needs are, transportation, things like that. So those are offered. It's whether or not the individual follows through. Oftentimes, when an individual is wanting services and they are admitted, they not only receive the medication, become stable while on the program. Oftentimes, they will show up. It's a matter of what's going on in their world outside of the jail once they're released.
Yes, Mr. Cathcart?
Yeah, on the previous slide, the dispensing, I'm curious, is that all, I assume it includes the jail in those numbers under the dispensing, but other than the jail, are those all dispensed at treatment services?
Correct.
And so I'm just curious on the naloxone piece, and are those given to reverse overdoses at treatment services?
No. So this is buprenorphine, otherwise known as Suboxone.
Okay, so we're just talking the Suboxone.
Correct.
Okay, all right. That confused me because I was curious. But so why is there such a trend down then the last 2 months on that? I'm curious if you have any thoughts.
So predominantly our individuals, the Suboxone, which is the trade name, does not quite meet the needs of their addiction, and it doesn't hold their withdrawals, their cravings. And so a majority of the patients that when they're coming and seeking services, the methadone doesn't have that ceiling effect. And so when they come in, their withdrawals are at a point, or their tolerance is higher than what the Suboxone or the buprenorphine naloxone can meet. And so and we do have several individuals that as they start on their own, tapering their dosage down with their provider, that when they get to a stable, healthy point that they can do it collaboratively, that they will make that transition and transition over to the buprenorphine naloxone. But it needs to be done safely so that they're not experiencing withdrawals and at risk of relapse.
Gotcha. Okay. Thank you.
Yeah. Oops. Any other questions? And any other questions on this slide? Yes.
Yes. Sorry. I know that there was some timing for the expansion of services and dispensing, I think, as well. When do you think you would potentially see increases in the numbers with the plans for expanding?
So our hope is that once we're able to offer that fully expanded time frame for intakes, because currently we are able to do intakes. We've been doing intakes and accepting new individuals as late as 12:30, 1 o'clock in the afternoon. So we no longer have that early morning limit. So that really has been a benefit. But we're hoping that we should be able to start seeing the expanded hours that will allow us to bring in more individuals at those later times. Honestly, it really just depends on when we can get the staffing in place and trained and open, and when that happens. I don't have that answer, unfortunately. I wish I could say for sure, but I don't know. Once we get up and going and open, I would anticipate it would only take a couple of months before we start seeing an upward trend. How much of an upward trend, I don't know. We'll have to engage that.
How have the Saturday open hours gone? Are people hearing through different networks, and are you connecting with a lot of the community social service providers throughout the region about being open on Saturday mornings?
Yes, and so Saturday mornings is specifically obviously for our individuals that are already engaged in services with us.
Okay, so that's not new. That's for people to come in and get their
Correct.
dose. Okay.
And that's where the Saturday expansion, it will be for new intakes, but currently it's specifically just to be available for our currently enrolled individuals to receive medication. And to your question though, how's that going? It's going well. The first week we had, I believe, 30.
Yeah, it's gone from 30 and last Saturday, I think it was up to, we were about like 49. So it's slowly getting more.
It's being utilized, and it's a great safety capacity or safety option for patients that maybe it's not a good option that they have weekend take homes.
So how is the hiring going for the expanded hours? I guess you probably have an update. There you go. Perfect
So,
segue.
give me just a second. On our medical slide, this is our annuals and our assessments for medical. And with that, I'll go ahead and go right into your question. So for the expansion update, we have had really good progress for recruitment. We do not have all positions filled. However, fingers and toes crossed, we should be able to get those at least offered, would be my goal in the next 2 to 3 weeks. I don't want to speak too presumptively, but that's the hope. So we have already actively working as our administrative assistant. We have security. We have a clinical assistant. We are currently recruiting for dispensing nurse, ARNP, and we have the 2 counselors ready to onboard soon. So we're still waiting for the ARNP, the dispensing nurse, and the counselors to start. Any other questions?
Any other questions? All right. Thanks for the update. I hope you can find those great folks to work with the health district, and I know we'll hear more from you next month. And I know the goal was like November 1 or so, but it depended on hiring.
Yes. So I would love to say that November 1 will still happen. It honestly will just depend on the recruitment process. And not just the recruitment, but the onboarding, because we definitely do not
Right.
want to
A lot
hire
of
somebody
training.
and push them into something that they're not ready for yet. So,
All right. Thank you.
thank you.
Kim, you're ready to go.
I am, let's see. Get the number going here. Good afternoon. Thank you for the opportunity to speak today and share with you everything financial going on in the district. So I'll move on to or I guess I'll start here. First thing I'd like to mention is the state auditor's office has been diligently auditing the health district for 2024. They started doing that just right at the beginning of June, and we just had our audit exit conference meeting last Friday, and as of this morning, our audit reports have been published. So we did send that out via email as well. So again, that was the financial statement, federal single audit report, and then the accountability audit report. And pleased to report that we had no findings and no management letter. We did have an exit comment about some language to put into a policy. And so very pleased. Thank you to everyone in the district for all their hard work and making that happen. And we also met the filing deadline. September 30th is the federal single audit filing deadline. So very pleased that we were able to do that early and not in a rush situation. So a couple topics today that I'm going to cover is covering the monthly financials for 2025. We'll go into the proposed fee schedule for 2026 and also the proposed budget for 2026. And then also a piece of the update will be from Mark Springer talking about the TV program, where we are in 2025 and beyond. So moving ahead. And one thing I'd like to also add is my the presentation on the fee schedule and the budget today is report only. This would be considered the first touch of the budget and the fee schedule, but we'll be looking forward to October's meeting for asking for approval through a formal resolution. So That's why there is not one in today's packet. And so beginning with August financials for, we're reporting on 2025. We would be at 67% of the budget. Oh, so August, through the month of August, 67% of the year. Our expenses are at 60.8% and our revenues are at 64.79%. So you'll see in the bottom right corner, we actually have a surplus to fund balance of 2.3 million. Again, this is a point in time. So this is where we stand for August. Items to note would be the Foundational Public Health Services funds that we receive. Those come in every January and July. So we've been advanced. In the month of July, you'll see 2.943 million under Foundational Public Health Services. And we plan to spend those dollars out through the rest of this calendar year. We also have the Public Health Appropriations, State of Washington funding, that also comes in July. And that is also for 6 months allocation through the end of the year. So those are advance payments prior to our expenditures. And then, of course, we have the third quarter county contribution that has also been received. And so that is to cover the next quarter of expenses. So overall, we have a 2.3 surplus for year to date. And then moving into reserves, we have, our goal is always 20% of the budget. And with that 2.3 million at this point in time, we're at 27% for our unassigned reserves. And that's reflected in the 15.7 million. We also have the board emergency fund reserves. Those are specific board action in order to touch those dollars at 1.5. And then assigned reserves are for specific purposes. We've set aside in dialogue with Budget and Finance Committee, setting aside some funds for future resources or other obligations related to fees. So for example, we have both buildings, 8th Avenue and West College, that we may have unexpected repairs or things to come up. So we have $1 million that we want to keep in that assigned reserve for to be prudent in those. Also, we have some building projects coming up. There's the Clean Air Act that has some requirements for some changes. And then we've also been working through, as you're aware, the masonry work on the brick building, brickwork this year, the windows and the roof carried into this year as well. So part of those dollars will be spent. IT, we had some carryover dollars to spend out, and that has been spent in January. Environmental public health is going through a software upgrade from an on-prem to a cloud-based service system. And so we set aside dollars to cover for that implementation and anticipate spending those. The other one is we have treatment services, electronic health records at the bottom of $350,000 for that new software. And so we have reserves to help cover for that. The others, EPH, solid waste, food, and schools are related to our fees. And I'll mention that when we get into the fee policy, but we strive to get 100% cost recovery and not run a profit in the fee programs. And so we establish our fees based on our anticipated expenses. If any of those programs run a surplus, then we put the funds here in the assigned reserve and we use those dollars to offset the next year's cost. So they're specific to those programs where they were generated. Treatment services expansion was the $850,000 that was allocated from a previous board meeting. And so that is sitting there for our expansion, and we may or may not have a need for that, but we have it set aside at this time. So total reserves is 22.146 million through August.
Quick question for you on that.
Yes.
On the screen change, but on the building projects, and I know we've talked maybe a little bit about some of this, but I'm not entirely familiar with all of the clean air stuff that we are trying to comply with. And so I don't know if maybe the next board meeting or sometime in there we could get a little just updated presentation on what that's looking like.
Yes, absolutely.
That'd
Love
be great
to do that.
And then could you just, what's the delta represented there in the additional 7%, the 27? What would be?
Okay. The 27% is where we are today.
Right, but what would it be?
What would it be at 20? It would be 20% of our budget on the next slide.
Okay.
which would be the 57, 573, 562. So 20% of that 57 million.
Of that, okay.
Yeah, yeah.
And do we have any policies in place around not exceeding the 20 to make sure that we're, putting the dollars to use?
We currently do not. That we do have just a reserve policy of what would be in the different categories of reserves, and then the goal of the 20%.
Okay.
But not necessarily how to utilize those additional reserves
Got
that
it.
exceed that.
Thank you.
Okay, on the proposed fee schedule, as I mentioned, I'm not looking for approval today, just want to go through as a report that's in your packets. And just to back up a little bit, as far as the budget preparation that occurs, we start back all the way in June to start discussing and reviewing our budget and looking at our salaries and benefits of our current staff as of June 30th. And then we work through with the programs and program managers and directors what their expenses will be, and they work through their budget. So part of the budget development is reviewing all the fees within their programs. So some of the highlights related to the fee schedule I would like to mention that we have resolution 2407 that is a Board of Health approved resolution related to the fee policy. And specifically, I'll read RCW 70.05.060 provides that the board shall establish fee schedules for issuing or renewing license or permits or for such other services as are authorized by law and the rules and regulations of the State Board of Health, provided that such fees for services shall not exceed the actual cost of providing any such service. So our intent is to strive for 100% cost recovery. And then if we do not, or if we run over in that, then we have the assigned reserves that I mentioned in the prior slide. And so what we're bringing forth is the proposed fee schedule based on the anticipated expenditures or known expenditures for each program that calculates fees. So just starting at the top on the fee schedule, we have general and administrative services, and there were no changes related to that. A lot of those are set by RCW, for example, the cost per copy. We just follow that. Vital records, the birth and death records that we provide here in our agency are also set by the state, have not changed for quite a while, so there's no increase or change to those fees. Then going through disease prevention and response and community health, we do not have any updates to the fee schedule as presented. Treatment services, our fees, we have Medicaid rates that are established. They come out in January. We also have contract obligations or contracted rates with insurance providers, and so they do vary based on the service. And all of those would be updated throughout the year or January based on the new rates. So there isn't an overall increase to treatment services fees. Under the outpatient mental health category, it shows a reduction of about 15% for fees. And actually the reason for that is the fee itself went up, but we have contracted rates that we're charging. And so it looks like it's a reduction to the fee itself. But really they're unchanged because we're status quo with those contracts. Environmental public health, again, we're covering costs. And so this year, it has become necessary to raise fees in some of the categories in environmental public health. And so we've gone through each of the categories that we have. For example, we have water rec facilities has an increase in the permits to operate pool, spa, wading pool. That's kind of the baseline fee. And then if there's additional services related to the pools, those did not increase. Solid waste, we did not have an increase in that category. And then liquid waste, specifically on-site sewage, we had an increase based on the hourly test rate. Of course, salary and benefits go up, so that rate is reflective. And then in environmental public health, we have the food program. And overall, not every category was increased, but we did have an increase to the complex restaurant and the limited food establishment between 6 and 8%. And then also the temporary food establishments,
the TFEs as otherwise known. That is where there's been some increases this year proposed for 2026. There is a new fee in land development, and it's to cover additional submittals after the initial final plat has been approved. So previously we did not have a fee, and we're proposing a $500 fee in 2026. And finally, the school services, we have permitting related, or the fee is based on the different schools and the capacity. So elementary 1 to 99, elementary 100 plus, secondary, so forth. And those have an increase this year based on our estimated costs. And of course, we have the expert Ray here present. So if there's if you want to dive into the details further, we have him here.
And one thing we discussed during the Budget and Finance Committee meeting was that some of these fees, especially the temporary food service fees, I guess we haven't made a change in those for many years. So maybe you could speak to that, Ray.
Yeah, so the temporary food have been consistent since 2016. So in 2014, the board had some concern about how we administered TFEs, so they formed that special committee. The work that they did wrapped up in 2015, which then reflected into the 2016 fees. So we have not touched those fees since then. Last year during the fee discussion that we had, we mentioned that we were running into temporary food events in particular were exceeding cost recovery in that. I mean, we're not making cost recovery. And so we had developed 2 new fees associated with large events to try and encourage promoters to take more activity in that and try and reduce our costs, as well as we took internal action to try and reduce that cost also. And we're still not there. So that's why we're seeing that across the board for all TFE events increase. And so again, we haven't raised those fees since 2015. They've been constant since 2016, sorry.
And I think you mentioned that coming out of the pandemic, when there probably wasn't very many activities happening, now I thought you had said in the committee that there's a rise in a lot of folks wanting to be out and about, and more food businesses pop up, events where folks are providing food. And so has the workload increased? Are you seeing more of these, the need for inspections?
We are. So since probably about 23 is when we started seeing that uptick towards the end of COVID. And it has steadily inclined since then. So we have added an additional 0.5 FTE, anticipating potential future increase also. But our workload around TFEs has substantially increased, not only in the number, but also in the complexity. So a lot of all of our TFE fees, if you see here, they're risk-based. So level 1, level 2, level 3. And we're seeing increase in that hazard. So they're going from level 1 to level 2 and level 2 to level 3. So it's increasing staff time, both in interviews and then also in inspections.
Just, I'll get to Councilmember Cathcart in just one second, but for those who are watching or listening who might not understand the hazard, can you give an example of like what would someone be serving in a level 1 versus a level 3?
Yeah,
in
so
terms of food.
Yeah, so level 1 are typically like hot dogs, pre-cooked items that have minimal handling or cooking requirements. It's basically cook serve. When you get into level 2, level 3, level 3s are cooking from the raw state, quite a bit of prep involved, hot holding, which each one of those increases the hazard associated with the service of that food. So as that level goes up, obviously the cost of the event goes up. Level 2 and level 3, we are required to do an inspection of those each and every event, which also drives that cost up.
Councilmember Cathcart?
Yeah, and I would love to just get with you at some point and just better understand a few of these. But I'm curious, like just for example, concession stand. Would somebody who is purchased or paying for that also have to get a TFE? Is that in addition to, or is that concession stand all that they need?
No, so concession stands are typically associated with like the arena, football stadiums, that kind of stuff. And that's an actual annual permit.
Okay.
So take out one permit. You can operate every weekend if you want. You can operate every day of the week. It's an annual permit. It's not associated with temporary food events.
but there's still inspections that,
Correct.
okay.
Yeah, so all of those other food permits that you see, we are required to see those at least once on an annual basis. And again, based on risk, some of those we're required to see twice a year.
And so I would love to just maybe get a better understanding of why, some of these have gone up a little and others have not, even though it seems like the workload would be similar or the same to address them. And I'm sure you could tell me that I'm wrong on that, but
Yeah.
I would just love to connect and just get a better understanding.
Okay.
Okay, anything else on?
All right, so if there are further questions,
Oh.
reach out to Ray, right? And to get some more clarity on the different, Commissioner Cuny.
Yeah, and I will say that's why this is our first touch. So you have time between this meeting and the next meeting to touch base with anyone and get questions answered on these or any of the budget items as well as the budget comes forward next. So just letting you know, that's why, I don't know, Kim, how many years ago did we institute that we did the double touch rule to make sure that everyone had an opportunity, because that is one of your primary functions, is the fiduciary responsibility of the board. So that's why we have a first touch today and then before the approval process next time.
And I know why Michelle asked to speak, so give us an update on who gets to vote on these fee increases.
Yeah, I'd just like to mention that the RCW 746031, when it was passed, specifically limits who can vote on the setting or modification of a permit licensing or application fee. And that is, it can only be determined by the city and county elected officials on the Board of Health. So just wanted to give everybody pre-warning on that. When we get to the vote on this next time, the fee schedule is limited to the elected members pursuant to the RCW. So just didn't want that to come as a surprise to anybody when the time comes.
So our appointed members don't get the joy of voting on the fees, but I appreciate I appreciate all the hard work. And if there are questions, that's what Commissioner Cuny was just saying. You have a chance over the next month, and we can just, we can have another touch on them in the committee. If there are concerns, ideas, and you need more clarification, reach out to Ray on the ones that are environmental health related, which are kind of the ones that we haven't looked at for a while. So, all right, ready to go into the budget?
Certainly. Okay, so here we are with bringing forth the first touch of the budget, as mentioned earlier. And as I mentioned, we did start this process back in June. It's a pretty lengthy process, and we start in June preparing the templates that everyone will use. We utilize the salary and benefit data from our personnel as of this June 30th date. And then July and August is working with our program managers and directors to go through their budgets, report and input any known or expected revenues, and then go through with their expenses. And if they're grant funded, they typically do their best to stay within that grant award. So we've gone through that process. We've also had 2 budget and finance committee meetings in the month of September. I presented twice to the Board of County Commissioners and brought forth some information. So brings us forth today to see the full board, have the full board see our 2025 proposed budget. And the first thing we'll start with is the expenses. So we have $31,831,462 in salaries and benefits, and you can see that's just over 50% of our budget is in the personnel. This reflects 282.25 FTEs for 2026. That's up approximately 6 FTE from 2025, primarily related to the treatment services expansion that we mentioned earlier. And then our supplies from 25 to 26, 1.1 million is down about 350,000 is a reduction there. Our services are up about $1.2 million, primarily from pass-through grant that we have in the early intervention, pass-through dollars for different contractors to provide services to those infants. And then, as we mentioned, the leasehold improvements current budget is about $1.7 million, and we're dropping down to 500 in this next year. So some of those major projects like the masonry work, the windows and the roof are being completed this year. And so we do have earmarked for 2026 some HVAC, some thermostat work that has to be done related into the building. So we can certainly share more information on that as well when we cover the reserves for building. So total budget for expenditures is 57.778 total expenses, and that's about 200,000 down from 2025. So we're practically flatlined this year on expenses and the size of our budget. Next, we want to look at funding, which is, of course, critical to those expenses on how we're going to pay for them. The first three are government funding sources, the federal indirect of $8 million. That was part of, or that's the section that is subject to that federal single audit that the auditors looked at this past year. They look at our federal grants. Our state grants are $21.9 million. Again, we do have a large program that has a large pass through to the service providers, and that's about 18 million of the 21 million. The Medicare, Medicaid dollars are primarily from treatment services and also our HIV program. So we did reflect some increased fee or collection of revenue related to the treatment services expansion is reflected there. Fees and permits are what we just discussed in the fee schedule, primarily from public health, environmental public health, and the vital records fees, birth and death records. Interlocal grants are specific to Spokane County grants, and that reflects the TB grants, as well as we have some pass-through dollars to another organization that's coming from Spokane County. Rents, we have parking lots that we collect parking fees from our staff on owned parking lots. So for example, we can collect, we collect from all staff, but the parking revenue in the basement of this building stays with the health district. The parking fees collected for the H lot, which is surrounding this building, is actually owned by Spokane County. So we pass those dollars on to Spokane County. We also collect rents now at 8th Avenue. We have a nice large parking lot there. So I think all staff are able to have a parking space, which here they're low on a premium. So we do collect $41,000 for rents. Then interest and other earnings is the interest income that we earn off of our fund balance on a daily basis. And so having, strong reserves helps bring in some additional interest income. This is also reflective of the higher interest rates. So 600,000 is projected. Donations and foundations are a little bit difficult to project, but we do have some unspent dollars in 25 that we're forecasting to spend into 26. They don't have a specific hard stop date, so those can roll forward. Question comes up a lot about public health appropriations. So this comes from the state of Washington treasurer. The 2877318 has been flatlined, stagnant for 15 plus years, has not increased or decreased. That money comes in every January and July for the health district, and that was replacement funds from the motor vehicle excise tax from long ago. So that's one of what we would call local dollars funding for the health district. Foundational Public Health Services, or otherwise FPHS, the 5.886 million is a decrease from 2025 by 150,000. So we did see a reduction in that funding stream. There's a component, 2,095,000 is flexible, what they call reinforcing capacity. So we can use that in any area that supports public health, foundational public health services. The others are very prescribed and specific to programs. But that is also what we would call the 2,095,000 as flexible dollars. And then our assigned fund balance usage, we do project to utilize some of those dollars that I mentioned in the previous slides that showed the reserve. So $1 million is what we are looking to utilize out of assigned reserve. So putting those two numbers together, we get to the point of where's our local dollar ask above and beyond from the other flexible funding of the state or FPHS reinforcing capacity. So we have a gap at this time of 1.378960. So that would be our local dollar ask at this point. going through the different divisions and the types of activities and programs that are supported by local dollars, either at the state level, county, or the reinforcing capacity. Just high level, we have administration, the communications department, our health equity department. The director, the administrative officer, is not an allowable expenditure for the indirect pool, so we have to pull that position out. So by default, it would be a local dollar ask. And then our employee accrual payouts at separation or unemployment costs. The employee accrual payouts are not eligible to bill to grants directly when we separate with employees. So that's by default a local dollar ask. Community health has a local dollar need specific to contract limits that are on the indirect rate for specific contracts. So the $18 million program that we have and pass through, we're able to hold back 5% on that, which is a significant amount towards our indirects. But we do have federal and state programs or federal and state funding within that program that have limits of either a 5 or 10% indirect rate. So we have to fill that gap. And that's what this is reflecting. And then lastly, we have disease prevention and response. We have the epidemiology program and data center that, although they have other funding, primarily foundational public health services, they do have a local dollar gap. And so this is a breakout of the $1.3 million ask.
Kim, I had a question on the contract limits.
Yes.
So that's mainly, so you're referring to the big pass-through that we have from the state for early childhood supports for kids that may need some extra physical therapy. I can't remember the name of the program.
We know it by ESIT, early support, infant and toddlers.
Okay.
But exactly that, the support before those kiddos get into.
So is there a way we can talk with the state to make sure that, because basically we're doing a service for the state of taking those dollars and then contracting with local organizations that provide those physical occupational therapy services. But you're saying that it doesn't cover all the costs of us administering the grant?
Well, it does. So there's several funding streams within the ESIT program. So the 18 million that we pass through, they don't allow for the full 24.43%. That's quite a bit of holdback on an $18 million pass through. So there's a statute, RCW, that restricts those dollars to be a 5% holdback, is the term they use, holdback. So we're projecting 920,000 to hold back towards the indirect rate. So we are collecting 920,000, or anticipate collecting towards the indirect rate. But we have two other contracts that are state and federal within that program, and they have limits of 10% or 5%. And so it's kind of a trade-off. We collect 920,000 from the 18 million in the indirects, and then we need 188 to cover the other two programs that have the cap that limits it. So overall, it's more than covering the indirect costs related to administering those programs. But sometimes there's grants that restrict and say, okay, we're going to limit indirects to only 10 or only 15. And so when we apply for grants, we're always looking at what's the other funding stream that's going to cover for that, because we still have that increased cost. But because we can get 5% on the 18 million, that's more than what the actual indirect cost would be to administer the program. And we have we actually have dollars, grant dollars that cover for the administering within the program itself. So this is just for the, the finance, HR, IT, those kind of support services.
Okay. Yeah, I just hadn't realized that those two other grants, we'd have to provide so much towards. So something to think about, but okay.
Yeah. It's kind of the way it shows. In the indirects, we get the 920,000, but then we have to give local dollars. To get the 920, we need to offset the 188.
Okay.
Good question. So Spokane County has a history of contributing to the health district, and quite significantly. I believe it's out of your general fund. So this is just a snapshot of what we've looked at like over the years and what our ask has been. And so this year, We are proposing 1.378960. This is down 675,000 from 2025. And we recognize the decreased funding situation that we're all in. And Spokane County had met with us early on to ask us to see what we could do with a reduction to our budget and to our ask. And so we're able to bring forth this reduction by asking for the 1.3. Now, in the assigned fund balance, $1 million, I mentioned we were going to use some of those dollars. That's where the building, we're anticipating using 500,000 for the thermostats, HVAC repair work in the building. The treatment services, EHR, spending 200,000 to finalize that new software. The expansion, we put away 850,000 in reserves, and this is an anticipated use of potentially in 2026. Again, it's somewhat of an estimate because we don't know what the counts look like yet. So of the 850 that we have in reserves, our budget currently reflects utilizing 242,000 of the 850. Environmental public health for foods and schools, those are dollars that we would have previously collected that were beyond what our costs were for the year. And so we're anticipating now using those to help offset and keep those fee increases down. But they'll be fully utilized in 2026. This next slide is related to 2025 and 2026 comparison for what we've asked with Spokane County. We asked for $2,053,960 for our flexible dollars in 25, and we've been able to bring that down to the $675,000 reduction. So that's where the 1.378 comes in. And then recognition that the county also supports our TB program, and that's considered more of a grant for us, an interlocal grant. Currently in 2025, it's at 420,885, and we're looking for an increase to the 525,855, with an overall increase of 104 for the TB program. So in summary, the total request, even though a reduction is the 1.378, if we net that with the TB program, we have brought our ask from the prior year down to 570,030 as an overall reduction. And we do have Mark Springer prepared to speak next about the TB program. So if there's any questions, budget, I'm happy to entertain those now. And
Councilmember?
Yeah, Kim, I'm just wondering, could you provide a version of the proposed budget that's broken down by program area to get a little bit more specificity on how the dollars are proposed to be spent?
Absolutely.
Great.
Would you like that compared with 25 and 26?
That would be wonderful, yeah.
Okay.
Thank you.
Yeah.
I think in our packet, it's just a 26 by,
Oh, yes, in the
by
packet,
division.
I apologize.
Division.
There's not a screen. That one currently in your packet is the agency roll-up. That left column is the full agency, and then each division and what those asks are by division.
so did you want more?
Yeah, broken
detail?
down within the division, the program
Okay.
The programs.
areas, yeah.
Certainly.
So are we anticipating any major changes to any of our programs then that we provide currently? to the
There is not a
community?
significant change to any of the programs. There is not a reduction in services or anything that you would see outside in the community. We do have two potential reduction in force related to grant funding that has either changed or reduced. And so although we're up 6 FTEs, that does reflect a decrease of 2.
So no decision on that, but there could be some changes, but not anything to our major outward-facing programs, is what you're saying? Okay.
Yes.
And Ray, you had mentioned the 0.5 additional. Was that in the last year that you had to add that for your permitting team?
Yeah, we did in 25 earlier this spring, we added a 0.5 into that. It was actually a reduction in one program. We shifted a 0.5 into the food program.
So it wasn't a change overall?
No.
Okay. Thank you.
Thank you. And I'll pass the baton to Mark, who can speak.
Oh, I'm sorry.
I'm sorry.
I have one quick question before you leave.
I'm sorry. I keep looking this way and I didn't see. So Patricia and then Dr. Blankowski me.
Oh, sorry, I didn't know you were going. Okay. I'm back at the audit exit conference. And I have a note, and if you can just explain this to me at the end, I wrote this down, but I wasn't sure about the actual timeline or how many audits this meant or what. So my note was, because they had a finding before, they are at a level of risk requiring more audits. But if lower risk, then a year after the next, that will change. And so I didn't know what that meant exactly.
Sure.
You know, how many audits have you had? When did that start? And what will that reduce the number? You know, do you
Great.
understand that? Yeah, okay.
Yeah, absolutely. So we have audits every year from the state of Washington Auditor's Office. And what they look at, they do the financial statement audit, federal single audit, and accountability. So you can get 3 levels of reporting or results from your audits. The lowest would be an exit comment, just some things to kind of clean up, suggestions, if you will. Management letter are more serious. They're in writing, and they're strong suggestions that if you don't make some changes, that they could result in the highest level, which would be a finding. And then when there's a finding, it's very prescribed by the feds, especially if it's on a federal single audit, the threshold dollar amount, if there's questionable costs or lack of documentation or a challenge with internal control. And so they're prescribed to issue a finding. And so if you have a finding, what results is that you're no longer considered low risk. They don't usually use the term high risk. They just say you're not low risk. So what that means is that if you're low risk, then the auditors will review 20% of the federal dollars that you received in the prior year. If you're not low risk, they look at 40%. So it increases what their coverage would be for the audit. And what they had mentioned in that audit exit conference is even if we're low risk, sometimes there's programs that are new or they're over the 750,000 threshold, and so they're type A programs, so they still have to do audits, and it still could be a 40% coverage even when we're low risk, and 20% that's all required. There's other samplings and rules on how they have to, what programs they have to cover. So we did have a finding a year ago related to a suspension and debarment lookup, and that was related to the external contract we had with Department of Enterprise Services, State of Washington, DES, and ultimately they did the RFP for us, selected the vendor, but it was our responsibility to ensure that they did the suspension debarment lookup, which unfortunately just takes about 2 minutes to do, as long as you keep the document. And so we couldn't produce the document that we had looked that up, and it wasn't looked up at the DES site program. So we received a finding because it was a federal requirement. And so it's probably the lowest risk finding. I mean, Commissioner Cooney could probably speak to that. It's a disappointment to have it, but it was related to one search that was not done, and we didn't have the backup to support it. So this year we had a clean audit, no finding. And so a following year, one more year, if we have another clean audit, we will drop back down to the low risk. Or
To 20%.
To the 20%.
Basically, yeah.
Yeah.
Okay, great. And I did want to say they said it was a very clean financial audit. And I think you guys did a great job, but I wanted to make sure I understood how
Certainly.
it all worked. So
Thanks
Thank
for
you.
joining the audit exit conference. And was anyone else able to join from the board? Okay. Well, thank you, Patricia, for doing that. Dr. Bukowski?
Yeah, I just had a question about anticipating any federal decreases coming up in the budget. I mean, you had a line in there of what's projected, and obviously you don't know the future, but do you have any sense of or anticipation for decreased support from the federal level?
Mm-hmm. Great question. We have a team, if you will. There's several eyes and ears through our program managers and directors monitoring all of the areas. Most recently, we have potential of a government shutdown as early as October 1. Will that impact our WIC program? That's usually has been impacted in the past. The state has dedicated reserve dollars to support the WIC program through a government shutdown, so there's no disruption in service. Although we do have to recognize the state is in also a different situation, so not a guarantee. So that's one thing to kind of watch in the immediate future. Also, our foundational public health services funding that's that's coming through the state, that is supported by the vaping tax. And from what I understand and what's been shared is that the revenue is not coming in as expected. And so they're anticipating a $4 million deficit in the future. So we did see a decrease from 25 into 26's budget. Fortunately, it was only 150,000 for us, but we do anticipate some movement with FPHS funding as a potential.
Thanks.
Yeah.
Also, I just noticed the donations, foundation donations.
Mhm.
Where do we get that? I know it's not a huge amount, but where do we get most of our donations from?
It's really it's like foundations, or it could be insurance companies. Like we've had Molina, we've had a Chaz clinic or Chaz, we've had Providence, and they contribute towards a particular program. We've also had the Quality of Life Survey. We get donations towards that or contributions towards that effort. And so it does fluctuate. It's kind of a delicate dance because we can't go and advocate or ask for donations, but there's certainly, if there's services that we're providing or they want to contribute towards, there's opportunities like that. So they usually are representative of a foundation and their funding is not state or federal. So by default, it would be what we consider a donation.
Yeah, I understand. I was just taken by some of the testimony we heard at the beginning that there might be some interest from the public to help support local public health, and I just didn't know where those donations came from.
We
but I
certainly
think
can
it would be
accept donations. We can accept them.
an interesting thing to put a button on the website, right? Thank you.
Yes, thank you. Okay, I'll turn it over to Mark for TB.
But I do think we should be keeping an eye on any federal changes from the CDC that might impact us. So something to follow up on maybe next month.
Absolutely. And there are calls, Ray's on, myself, and others that are
yeah.
liaisons with DOH.
I'm part of the health committee of the National Association of Counties, and I think we have a call next week. So if I have any other info, I'll also share it.
Thank you. Mark.
Thank you. Thanks for giving me the opportunity to talk about the TB program. I'll just give you a little bit of an update. I'll provide a little bit of context to TB and talk a little bit about a program and then some of the challenges that we've seen with kind of the expansion with that. For just context about TB, I mean, this is a bacterial infection that often is a pulmonary infection that impacts people in one of two different ways. And so we kind of classify TB as a latent infection, and this is what we would traditionally look at as like a carrier. Someone who has a TB infection, they have TB in their body, but they are not infectious to other people, and they're generally not symptomatic. And most of our attention is not spent on latent TB infection. Most of our attention is focused on TB disease. And this is where a person has symptoms, and oftentimes they're infectious to other people. And why I bring this up is because oftentimes we look at TB as a disease, that's international in flavor. It comes from overseas. There's a lot more TB across the world. But even looking at the prevalence here, that you can see with LTBI infections, in the US, there's a significant burden of LTBI or latent TB infection to the estimate of about 13 million people. And that's the burden that we work with, because those are people who convert over time, even at a small percentage, to TB disease, which is what we manage here at the health district. Oftentimes there's questions about why TB is managed from a public health perspective. So I wanted to kind of talk about some of the challenges with medical management of TB. This is a somewhat rare disease with looking at TB disease, people who are symptomatic, and oftentimes because it's rare, we see challenges in terms of diagnosis. Often a lot of our cases come from the hospital. someone's been admitted, they're often very symptomatic. But a lot of providers in primary care don't see a lot of TB, and so often our cases come fairly advanced. The populations that we see TB in are often high-risk populations that are challenging to manage in a medical setting. Oftentimes, these are people who are born overseas. They may have limited English proficiency. There's challenges with access to health care, where oftentimes they may not have insurance. Oftentimes, they don't have a primary health care provider that might identify TB at an early stage. And it is a disease of poverty as well. The challenges that we primarily deal with, I think, from our patient population, often is about access to healthcare and language. Those are the things that keep people from being evaluated in a traditional medical setting, and often make it challenging for providers to manage cases of TB. And the reason, the last two bullets in terms of why we spend so much effort from a public health perspective in managing TB is if we get this wrong, if someone is not managed appropriately, because the treatment duration is often quite long, if we get this wrong, they're going to relapse. They're going to be potentially infectious to other people for a prolonged period of time. And there is a significant risk of developing drug-resistant TB, which has its own challenges in terms of treatment duration, can be well over a year. The cost of those medications are very, very significant. And so our goal from the public health perspective is to make sure that people with TB disease are treated, we do those contact investigations, and we minimize the risk of one of these bad outcomes. Well, I think I skipped a slide, so let me come back to public health. Part of how we manage TB is with directly observed therapy, and this is with a nurse or a public health worker who's administering the medication or observing the medication being taken. And this is a critical component to effective TB therapy. Again, if we have someone who feels better, by 6 to 8 weeks and discontinues their medication, that's where we're going to see a relapse. That's where we're going to see someone potentially at risk of drug-resistant TB. And that's where we see a lot of challenges with management of TB disease in traditional medical settings. Oftentimes, we have a contact investigation when we identify someone with TB disease, and that starts with the household, could be with an employer. We want to identify other people who may have been exposed to that person while they were infectious, and identify if they have latent TB infection or if they have TB disease, and get those people treated. And then we have a wide variety of supportive services that we offer around TB that really make sure that we get across the finish line in terms of getting people fully treated and cured of their TB. And a lot of those are wraparound services with transportation to providers, interpretation services, other things that we need to do to make sure that they're successful in their treatment. I wanted to put this snapshot in terms of looking at TB deaths, just because, this is a very serious disease, and even with us being able to manage these cases, and we do a really good job of managing TB disease, and our numbers are very good, but we still have TB deaths, and this comes about, I think, in many cases because people are being diagnosed very late in the disease. They have a lot of other chronic medical conditions that lead to progression, and it's a very serious disease. And I just wanted to bring that out, even with these numbers, even with us being in a great city with a lot of medical options for treatment and great hospitals, we still see TB deaths in Spokane County. So kind of looking at the work of the TB program, a lot of what we do is around TB case management, and that's kind of that first bullet. But we also do some work around managing latent TB infection in certain specific settings. There's some quality assurance with working with Unify. They manage some of the Class B TB screening that happens here in Spokane. There's some training and education that happens with healthcare providers, and then we also manage some of the TB testing of staff here at the health district. Our current staffing model is we have 2 nurses and 1 community health worker. And we're very thankful that the board approved having a new TB nurse hired with the 2024 budget. That was a godsend for us, with just having one nurse here to provide TB services for the county. Each of those nurses has their own patient load that they manage, and there's some cross coverage between the 2 of them for vacation or leave. We also have some cross coverage from our communicable disease program, where we have some staff who are trained to do some search support for a TB program as well. What I wanted to do with this graph is to kind of really point out what that load looks like, because when we talk about having 11 or 12 patients in a year, that doesn't look like that much, but when we think about what does TB case management look like, this is DOT, daily observed therapy, where we're going to a patient's home Monday through Friday, for if they're on 6 months of therapy, for that 6 months. And so what I included here are, cases of TB disease, latent TB infection that we manage. And oftentimes these are people who have LTBI that were identified in the case investigation, but maybe they're in the person's home, their household member, or identified in that way. And then I also put the contacts that we manage. Those are the people identified in the contact investigation. Usually we're working with those people over a 2-month period of time, where we're screening them at the beginning of that contact investigation, and then 8 to 10 weeks later to make sure that they did not develop a TB infection. Now, these numbers are representative of what we did early September. We are not including anything with the recent contact investigation that happened at Eastern State Hospital, where we had an individual who had TB disease, a worker there. And within that context, that case investigation is still ongoing, but that was 193 people screened between patients and staff. So it's a significant, ask, with our TB program, and we didn't do, most of that screening. A lot of that was with staff at Eastern State Hospital, but there's a significant consultative and coordination component with that. So we are seeing some significant challenges, in terms of capacity right now. Our TB staff are often working, 10 to 15 hours of overtime per week, just with managing, the DOT schedule with the large number of patients that we have right now. We're having to do a little bit of triage with that. We're deprioritizing a little bit of work that we can shift off that's not direct patient care. So there's not a patient risk at this stage with the volume that we have. We are working to address some of those issues as much as we can. We're shifting, some staff to be able to help with that. We have a DIS who's been working with the TB program with the nurses in terms of helping with DOT, where we have a fairly established patients or established patients who are fairly simple in terms of the nature of the follow-up. And that's helping a little bit. And we're having some additional support from Department of Health with the investigation at Eastern State Hospital. And that's been really important for us to have those relationships. So what we're doing here is just bringing this up as just a way to bring this information forward to the Board of Health and kind of give you some situational awareness in terms of where we're looking and what are the options that we have in front of us. So there are a couple of options, in terms of how to provide some additional support, at this stage. I think there's always a conversation when we look at this of, well, why can't we contract out with an infectious disease clinic or another group, a clinical group, to take care of some of the burden of the DOT. That's really challenging in a lot of respects. This is not really the model that most of those clinical settings work under. It's office-based medicine. It's not necessarily, sending a nurse, to a person's home, to be able to do that type of work. And again, we have to maintain that DOT so that we minimize the risk of disease reoccurrence, infecting other people, or the concerns about multi-drug resistant TB. We can look at hiring non-clinical staff, like a disease investigation specialist, which is kind of what we're surging with supporting the TB program with a disease investigation specialist right now that provides us some flexibility within our program. Our challenge with that is, if we have something where we have a new contact investigation or we have other pieces where we really need the clinical requirements of a nurse to be able to do that evaluation, to collect blood specimens, to be able to manage a complicated case and that portion of the case investigation. That a DIS provides us some utility, but it's not the Swiss Army knife of being able to respond to any situation, in that sense. So those are kind of the three things that we were looking at and wanted to bring up within this group. And I'll come back to that a little bit, but Kim did ask with, kind of looking at this, that we kind of talk about some of the TB budget considerations, with what does TB case management look like from a fiscal perspective. So looking at the revenue, in addition to the county contribution, which is where most of our funding comes from, there are a number of other sources of revenue that we have in terms of FPHS dedicated funding for TB. We have some pass-through funding from CDC that supports us for TB work. We do get some Medicaid match reimbursement for our TB nurses, and that provides us some additional reimbursement as well that we can offset the county expenses with. This is our 2025 and 2026 proposed budget. I want to call attention to a couple of pieces on this, and certainly willing to entertain questions in other areas. One of the areas that often comes up as a question is that client compliance and food, and what does that mean? Oftentimes with TB, we're isolating a patient for a period of time. While they're infectious, we may be pulling them out of their home or taking them off of work, where they can no longer work during that period of time where they're infectious. So there's a component of those expenses that are related directly to isolation support. We also do have other things that we need to do to get people across the finish line. Some people don't have a phone. and it's hard to schedule appointments, for DOT and other things. So we will provide people at times with a cell phone if we need to, or a prepaid plan, so that we can reach clients. We've had to provide other types of support, in terms of medications or housing or other things like that. When we have situations where we may lose a client. I mean, we've had TB patients who've come, to us unhoused into the community, and at least for a short period of time, we have provided housing because we do not want to have a situation where we are risking TB in a shelter setting or in another congregate setting. So we have done a few things around that with regards to risk reduction in terms of managing the risk to the community. And then we obviously have some medical expenses, as you can see, with the standard services at $25,000 in 2026 relates to medical expenses that we have for evaluation of TB disease, and I'll go over that in another slide. But those are the main things, and I'll go into those in a little bit more detail as we move forward. In terms of the medical expenses, we have kind of three main sources of expenses that we have. And we do a blood test, a quantiferon test that tells us if a person has a TB infection. So if we're doing a contact investigation, we're doing that for everyone who's identified as a contact. This is our next generation alternative to the TB skin test that we may have remembered from having in the past ourselves. If someone has a positive test, a blood test for TB, then we will go with a chest x-ray to identify if they have TB disease, especially if they have symptoms or respiratory symptoms. And oftentimes we have to use those imaging modalities, whether x-ray or CT, so that Dr. Velasquez, as he's evaluating the progress of a TB patient, can see the changes in terms of their pulmonary findings from, during the course of treatment, because that's a necessary component to seeing if they're making appropriate progression in their treatment. You can see the diagnostic costs below. Those are kind of 6,000 and 8,000. There are some possibilities of shifting some of those expenses, potentially, referring those out to a provider to see if that can be billed through that insurance in that way. Oftentimes, when we're initially evaluating a person for TB, that's not really a cost-effective route, because it's much easier for us to do 8 blood draws during a contact investigation at one time, rather than trying to follow up with 8 different healthcare providers and making sure that that person has transportation to get that test done in those settings. So that's oftentimes why the TB program assumes some of those expenses.
Mark?
Yes.
I know some board members might have to take off here soon.
Yes.
So this is great. It's very detailed. Maybe, I think if you want to get to the staffing piece.
I will shoot forward.
I hear that you're talking about that there's options, but there's challenges with the changing some of the imaging and and I appreciate that you have the different options for hiring different folks or contracting out and the challenges with that. So yes, thank you.
I will move
we
us
will
along.
follow up with more questions. I think this has been a great presentation, but thank you for getting to the recommendation. Appreciate it.
And our recommendation at this point is to look at hiring a TB nurse to provide us with that flexibility with that. We still have the ability to do search support, using a DIS. But right now, with the TB load that we had in our search support, our DIS is only able to support 3 of those patients with DOT based on the complexity that we have with our current patient load. So our recommendation is to move forward to look at adding to our team with a TB nurse. Yes, Councilman.
Yeah, I mean, obviously the grant dollars come from the county, so I would in large part defer to them. But my thought would be that you would start with that billing specialist to start generating additional revenue to hire the additional medical assistants. But that's just
Yeah, that's a very good question, and I think that's something to explore. I'm not sure if our volume in terms of billable expenses is going to get us that much, with kind of a proportional billing specialist with that. I mean, we would have to share, part of a treatment services billing specialist, with that. And that's a little bit of our challenge. With TB, we don't have an electronic medical record or paper charts, so there's going to be an administrative burden with that. And so it's a question of, can we make that work in the positive and get us in the black with that? But it is something we're thinking about.
And so I guess my question was, if you go back to the budget, the proposed budget, you're asking for $104,000 increase.
Correct.
But that's because that wouldn't cover, I wouldn't think that would cover the cost of a full nurse, but you're finding other areas to cut back is what
Correct.
Okay.
Correct. So what we're looking at is, can we streamline some of the the patient supports, can we streamline that piece a little bit so that we're a little bit more cost effective? For example, with the CT imaging, we're not time bound on that, so we can work with some of, try to get those done through primary healthcare providers for people who have that, maybe facilitate that person to get a primary healthcare provider. There's some additional burden with that, but that's a way that we can reduce some of the diagnostic testing expenses. And so I feel like we have a few areas where we can find some cost savings.
Commissioner?
Mark, thank you for this information. This is great. I did have a question. I mean, as you look at 23, 24, and 25, I mean, it was 12 cases, and 11 cases, respectively. Are you expecting to see an increase in years going forward? Is that what's necessitating the ask, or do you think we're pretty level, but we're just not providing a level of have we plateaued, but we're just not providing a level of service that we think is at where we need to be?
I'll maybe jump in really quickly, but leave it to Dr. Velasquez as he can comment a little bit on the complexity of the patients. I think we're going to continue to see, more patients with TB disease. Part of this is that we are really just getting the sickest of the sick where they're being diagnosed at the hospital, but there's a burden to that I think is not going away. And sometimes when we think about TB being an international disease and we're seeing fewer refugees coming into our community, that's not going to solve anything with this. Unfortunately, we have a large proportion of citizens in the county who were born overseas or have family members born overseas where they could have acquired latent TB infection through that route. And people with chronic medical conditions who have latent TB are more likely to convert to TB disease. So I think we're going to see, I don't see us dropping down. I think this is going to increase at some steady rate. But Dr. Velasquez, you're a little bit more in tune with the complexity of what we've seen.
Sure. I guess the way I would describe it, this is not a variance, this is a trend. And that trend is trending upwards and will probably continue to trend upwards. And there's a couple of other factors. One is the patients we're seeing, it's not your typical traditional pulmonary TB. We're seeing TB pretty much in every organ system that you can think of, which makes the treatment and complexity escalate. So each one of these patients is taking a lot longer and a lot more time to provide the services, which is the reason why our nurses are running, 15 hours a week or whatever it is of overtime, which is not a sustainable model. Because if one of them were to be sick or something, we will be in a world of hurt. That's a clinical term. So, but And that has to do with the demographics and the migration shift we've seen in Spokane, which is not going to change anytime soon. So we are confident this is a trend. And to make sure that that overtime doesn't become so excessive that we cannot even cover, we need to start thinking about adding the resource and for the complexity.
Thank you.
Yeah.
Okay, well, I know that Commissioner CUNY had asked that when we were discussing this in our budget finance committee for a deeper dive. So I really appreciate, Mark, all the detail and the options that you've laid out. So I think the next step is to, if we have questions or need to dig into it further, talk with you or Dr. V, and then bring that back to the Board of County Commissioners, because ultimately that's where the TB funding comes from, right? Okay. But this was really good for the whole Board of Health to understand the impacts of this disease in our community and the complexity of the cases. So thanks for doing that. Really appreciate it.
Thank you for the opportunity.
Okay. We'll be having more follow-up and about what our options are for 2026.
Okay.
Okay.
Thank you.
Dr. V, I know you wanted to give just a brief update, especially on the any issues with measles in our community.
So thank you. So I may make a recommendation. I can do two things. One, direct you to the measles response handout that is in your packet, which is the area that I wanted to focus, because this is an example on how disease prevention response works and is a very effective model. And then next meeting, I can give you a little bit of the highlights of where we're at. The good news is thank you to the effort of not only the team here, but all of our partners. We're cautiously optimistic that we have contained. We have one case, an infant that because of age is not immunized. And this could have been a potential snowball effect like we've seen in other parts of the country, but we have not seen that yet. Cautiously optimistic that we'll keep it there. Caveat, there's a lot of measles all over the world and all over the states, so travel related may be a concern. But I'll come back on the next board meeting and give you a much more fuller response. But this is a great document for you to look at, which is directly from our SIT reps, just so you have that information. Thank you.
Thank you. And I just did a quick glance, and I think you have some good information here about the percentage of children getting vaccinated with that MMR vaccine and the process of and what happens if we don't have enough children that are vaccinated. So thank you, Doctor. All right, then I think we're at the end of our agenda. Just board member check-ins. Anything to check in? All right, I just wanted to say that I know we're going to be working on the state legislative agenda. So Councilmember Cathcart, I think we wanted to have an initial, you guys are maybe going to have a committee meeting and then bring something back to us to touch in October for a final decision in December.
Yeah, staff has already provided a rough draft. I think we'll review it. I think it's Monday is the committee meeting, and then feedback, recommendations, tweaks, whatever it looks like, we'll come back to this board.
And that reminded me that I think Liz Henry jumped off the meeting earlier, but we probably need to assign her to a committee if we haven't already. Were you already thinking about that, Anne? I see you smiling. She's always one step ahead.
Thinking about it, but actually it's the board chair that would have to appoint her.
Okay, so I will reach out to her and find out which committees she wants to serve on and get that moving. And then the only thing I was thinking about is we may want to also look at just are there any changes at the federal level that we may want to be monitoring? I think there are some, so that may be something we want to consider for this year are there concerns at a federal level that this board may want to, weigh in on? So if you guys could maybe have a brief discussion, I'm happy to pass on anything that I learned from the NACO call I have next week, the National Association of Counties. So, okay. All right, then we are adjourned. Thank you.